Good evening, everyone. I would like to formally welcome you to the first official webinar of the Southern Thoracic Surgical Association. This is a new initiative that we've decided to embark on, and we are very excited this evening to have Dr. Mara Antonov, who will be introduced shortly. The format for today will be the Dr. Antonov's presentation, Q&A, and then stay tuned for some important announcements from STSA. Again, thank you for coming, and we're so happy that you're here. Dr. Lauren Barron will take over. Dr. Barron is the chair of our communications committee.
Good evening, everybody, and I'm so glad you're here with us. Tonight, we're going to start out with Dr. Antonov giving us the first of a few briefings on what's next in the field, sort of what's going to be the next topic and what's being talked about amongst the change makers of our field. Moderating tonight, we have Dr. Fatima Wilder. She's a thoracic surgeon at Brigham and Women's Hospital in Boston and at the Boston VA Medical Center. She's an assistant professor at Harvard and an associate PD for the I-6 thoracic surgery program. All you students, she's the associate PD for the I-6 thoracic surgery program. She completed her medical training at The Ohio State, her general surgery training at Rutgers and UCSF Fresno. She did a research fellowship at Memorial Sloan Kettering and then went to Johns Hopkins for her CT surgery training. After all of that, she got a master's of public health at Harvard. Her clinical interests include lung cancer, chest wall, and mediastinal diseases, and she serves as a committee member and leader in several of our national societies, including ABCTS, STS, STSA, and WTS. Her research focuses on better understanding how the social determinants of health impact thoracic surgery patients and designing interventions to address the social needs of patients with lung cancer. Our panelists this evening are Dr. Ian Bostock, who is board-certified thoracic surgeon at Baptist Miami Health Center. He specializes in treating lung and esophageal cancer, as well as mesothelioma, mediastinal and chest wall tumors, and benign esophageal diseases. He serves as an associate professor of surgery at Florida International University. And prior to joining this Baptist Health, he was an assistant professor at the Department of CT Surgery at the Medical University of South Carolina. We also have Dr. Alexis Chidi. She is a cardiothoracic surgeon scientist and the co-director of the lung cancer screening program at Memorial Sloan Kettering. After earning an MD and PhD in clinical and translational sciences at the University of Pittsburgh, she completed her general surgery training at Johns Hopkins and then her CT surgery training at the University of Texas MD Anderson Cancer Center. She also holds a master's degree in health policy and has work experience in the global health and pharmaceutical industries. Her research examines healthcare delivery and cost effectiveness of screening and treatment for thoracic cancers and end-stage lung diseases. Her work, interestingly enough, has been presented at the typical academic national meetings, published in high-impact journals, and highlighted at President Barack Obama's White House Frontiers Conference. And if you Google her, you will get to see an outstanding talk that she gave. And with that, Dr. Wilder, I will let you take it away.
Thank you so much, Dr. Barron. It is the Southern Thoracic Surgical Association's privilege to kick off the series with Dr. Mara Antonov discussing what's next in the treatment of stage 4 lung cancer. Dr. Antonov joined the faculty at MD Anderson Cancer Center in Houston in 2014, where she's currently the Associate Professor of Thoracic and Cardiovascular Surgery and a Program Director for Education. She's the Deputy Head of Education for Surgery, and she runs the Cardiothoracic Surgery Training Program. Dr. Antonov's research interests include local consolidative therapy for stage 4 lung cancer, tumor response to neoadjuvant therapy, pulmonary metastatic disease, and early detection of lung cancer. She is the surgical lead for several trials evaluating the role of local consolidative therapy for metastatic non-small cell lung cancer. She's authored over 400 publications to date, as well as dozens of book chapters, teaching aids, and online resources. She holds several leadership roles in the Society of Thoracic Surgeons, including the chair of the STS Council on Member Engagement and its Leadership Institute. She serves as the president of the Women in Thoracic Surgery. She further holds leadership roles within the AATS, the STSA, the Association for Women Surgeons, and the International Association for the Study of Lung Cancer, as well as the ESTS and the TSDA. She holds senior editorial board positions for the Annals of Thoracic Surgery, the Journal of Thoracic and Cardiovascular Surgery, Innovations, CTSNet, and the Journal of Thoracic Disease. So we are very excited to hear from Dr. Antonov tonight. And without further ado, Dr. Antonov, the stage is yours.
Thank you so much for this phenomenal privilege. I'm certainly humbled by having the opportunity to be the first presenter in this series. I hope you all can see my slides okay. Um, I think as we talk about really expert briefings on emerging practice and where the world is changing, I think I'm super excited to be able to talk about where we are changing in terms of the role for surgeons in stage 4 lung cancer. And I know that the Southern is comprised of surgeons who are general thoracic surgeons, cardiothoracic surgeons, congenital cardiac surgeons, and really a lot of people who have mixed practice. And I think ultimately there's so much that we can learn in each of our subspecialties from one another that can help really drive innovation in each of our fields. So I'm super excited to be able to talk to you all about this. And I hope that that the conversation after the presentation is just as vibrant as all of the wonderful individuals on the panel. So I think without any further ado, I do think I probably owe you all a little bit of an explanation as to why we're talking about surgery in stage 4 disease. I do know that surgery is something that we do that's a local treatment, and stage 4 is metastatic disease. It's a systemic problem. And we usually think about surgery as being curative for early malignancies. And I want to point out a little bit about the NCCN guidelines over time. Many of us look to the NCCN guidelines to help advise ourselves on really how to manage really any malignancy. So let's just take a step back and look at 2001. For metastatic disease, the NCCN talked about different lines of chemotherapy. Oops. Slides are flying. Different lines of chemotherapy and with no recommendation for anything other than chemotherapy. But if you look at early stage disease back in 2001, I would also like to point out at that point, PETs were optional and mediastinoscopy was required for resectable stage 2 and stage 3. So certainly we've seen changes in the way that we treat early stage disease with time. So why shouldn't we see changes in the way that we treat advanced disease? Looking at the NCCN guidelines in 2012 for metastatic disease, at that point, when we talked about disseminated metastases, surgery wasn't an option. Really, it was for patients with solitary metastases to the brain or the adrenal. If patients had any pleural effusion, then surgery was not an option. If patients had any nodal disease, surgery wasn't an option. But here we are in 2025, where we see that it does matter if the patient has metastasis to the brain or to other sites of disease, but ultimately, regardless, surgical therapy can be considered for any of these patients. Now, I will say that the NCCN says that they need to be N0 or N1, and we can talk about that a little bit further. But ultimately, I think it's important here to see that the guidelines definitely are changing over time. And how did this happen? Certainly, we're used to stage-dependent treatment of any type of malignancy, with stage 1 disease and lung cancer traditionally treated with surgery. Stage 2 and stage 3 have really for quite some time involved a combination of surgery, radiation, or systemic therapy. But for stage 4 disease, the mainstay for quite some long time has really been on systemic therapy, and surgery is really not something that we typically consider. So here we're in this situation where there's an evolving management paradigm, and there's clearly a change in our approach for metastatic disease. But we are scientists, so what are the data to support it? I want to start by talking about oligometastatic disease, because from my perspective, I think of oligometastatic disease as being really the gateway to surgery, where we can see issues such as oligometastatic disease that may just be oligoprogressive or polymetastatic disease, potentially walking through that door to surgery. But within the realm of stage 4 disease, oligometastatic lung cancer definitely has led the way with the most evidence, really creating a pathway for more extensive disease and more aggressive disease to be considered for resection. And I would say that while my practice and that of my partners at this point does at times in the right selected patients involve operating in polymetastatic disease or oligoprogressive disease, or patients who may have had a previous malignant effusion, I think the greatest body of evidence lies in oligometastatic disease. And this is really where we need to start thinking about it to understand how we got where we are. Oligometastatic lung cancer is the idea of really just a few sites of disease, not necessarily only one, but typically in our definitions of many of our trials, we think of it as 3 sites of disease with all of the mediastinal nodes considered one, or all the intrathoracic nodes considered one site. This is a potential opportunity for maybe more aggressive local therapy, recognizing that the oligometastatic state is one of a limited disease burden with distinct tumor biology and a spectrum of associated outcomes depending really on how aggressive these different tumors may be. I absolutely need to point out the landmark oligometastatic trial that was published in Lancet Oncology in 2016 with Dan Gomez as the lead author. Many are familiar with this landmark paper. And importantly, in this trial of patients, again, who had oligometastatic disease, so 3 or fewer sites of metastasis, those individuals who had local consolidative therapy consisting of surgery or radiation to the primary site of tumor, as well as all other sites present at the time of diagnosis, had improved progression-free survival, which is shown on the left, and improved time to development of new metastatic lesions, which is shown on the right. This trial stopped early because it was required to do so because of the profound benefit seen in PFS and new lesion-free survival for patients who are receiving local consolidative therapy, again shown in blue on these figures, as compared to the patients who had maintenance therapy or less aggressive therapy shown in red. And again, as I was saying, comprehensive therapy or local therapy to all sites of disease present at the time of diagnosis further led to even further improved PFS, time to development of new metastases, and overall survival. This was incredibly fascinating. And I think when we saw the results of this trial, the question that I had is, which patient subgroups are most likely to derive benefit? We don't totally know. And moreover, what about which patients would be best to be considered for surgery after preoperative systemic therapy, recognizing that we used both surgery and radiation in this trial, and we want to understand which patients really are going to benefit before we take on something potentially as risky as surgery. So this was a study that we did in 2019, published in 2020. And this was a retrospective review of almost 200 patients that were identified using a novel natural language processing algorithm to look for patients with synchronous oligometastatic disease treated both on and off that oligometastatic protocol. Ultimately identified, again, almost 200 patients. You can see that we began with patients who were treated anywhere between 2000 to 2017, so an 18-year period, and identified these patients who survived at least 12 weeks after their diagnosis. And again, use the same diagnosis, 3 or fewer sites of disease with intrathoracic nodes equating to 1 site. And importantly, you can see here in this figure on the right that patients who had comprehensive local consolidative therapy, meaning local treatment to all sites of disease present at the time of diagnosis, had better survival overall than patients who had either just systemic therapy or systemic therapy with subcomprehensive local consolidative therapy. This was statistically significant, and we saw that this upheld at 1, 3, and 5 years of overall survival evaluation with an adjusted hazard ratio of 0.64. So this was a big deal, and this is looking back retrospectively over time in patients who were maybe treated more aggressively than what would have been recommended on NCCN guidelines during those years. Moreover, within the same data set, we looked to identify prognosticators of overall survival following this comprehensive local consolidative therapy. And what we found was that patients who had non-squamous histology, patients who had lesser intrathoracic stage, and patients with the absence of bony metastases tended to have even better overall survival following comprehensive local consolidative therapy. Now, even though I'm really proud of this paper, I do want to point out one major flaw, a huge limitation to this data set, because there are aspects of this that I don't apply to my daily practice any longer. I just got done saying that patients who had bony metastasis had not as great of an overall prognosis after comprehensive local consolidative therapy. It's really important to understand that in the data set, the cohort of patients who were in this study that we published in 2020 and in 2019, that these patients, the majority of them, did not have oncogene-driven disease. They tended to be an older population. They tended to be on systemic therapy that most often consisted of cytotoxic chemotherapy. And this was in an era prior to extensive use of immunotherapy, and certainly before most of our targeted therapy that we have now. I think that's really important to recognize, because when we talk about patients with polymetastatic disease in this current era, patients who have extensive bony metastases, and these individuals, when you can give them a targeted therapeutic agent to which they are tolerant and they can take it for a prolonged period of time with minimal side effects, take it by mouth, and have a prolonged result, then those patients tend to do really well, and they tend to respond very well in terms of the bony metastasis. So I don't want to discredit this important publication in oligometastatic disease, but I do want to be very clear that we have to continuously think about the cohorts that are in these trials. And I think this is relevant whether we're talking about stage 4 lung cancer or valvular disease or anything else. When we have these important studies, we really have to know who the patients are who are enrolled and recognize that in this group of patients, the presence of bony metastasis was problematic. And we do have emerging research that hopefully I'll be able to share with you all in the coming months to years that maybe suggests that patients with driver mutations, that perhaps the presence of bony metastasis is not as terrifying as it was for this initial cohort. So what about lung surgery specifically in oligometastatic disease? This was a subgroup evaluation of patients who specifically had lung resection, not just local consolidative therapy of any sort. And I show this slide to a group of surgeons, but recognize that I need to tell you this is a little bit flawed. This is looking at our initial cohort that we evaluated of patients from 2000 to 2017, so an 18-year period. For both surgery and radiotherapy, 90-day post-treatment mortality was quite low. And after a median follow-up of almost 5 years, the median overall survival after surgery was almost 5 years, and after radiation, just under 2 years. However, you cannot compare these groups head to head. It's not fair. We operated on the best patients. And so you certainly can't get rid of the fact that there's clearly selection bias and confounders in this group. We didn't use these results to say surgery is better than radiotherapy. We use these results to say, listen, we've demonstrated that local consolidative therapy makes a big difference for patients with oligometastatic disease, and we surgeons need to have a seat at the table. Patients with stage 4 lung cancer have a right to meet surgeons, and surgery needs to continue to be part of the conversation. That's not to say that it's necessarily better than radiation. We don't 100% know. We'll talk about that a little bit later, what the different benefits and drawbacks might be of surgery compared to radiation. But this was us putting our foot back in the door and saying, please, we deserve to have a right in this group of patients, and we may have something to offer. So please recognize that surgery can offer a benefit to these patients. One of the questions that gets often brought up is, but is surgery safe? Isn't it so much more complicated? Well, let's talk about surgical complexity in metastatic disease, starting with oligometastatic disease. If the management of patients with stage 4 disease is rapidly evolving, and we're saying there's all these benefits, local consolidative therapy, it's feasible, there's some long-term survival benefits, we have to understand the technical aspects. And so we did aim to review the technical complexity of these operations. And when we looked at these procedures for one of our data sets, I can tell you the majority of them were performed through mini muscle-sparing thoracotomies, all with enhanced recovery protocol, but most of them were not done minimally invasively. Most frequent operation being lobectomy. Estimated blood loss, operative time, very reasonable. I do not think that estimated blood loss or operative time are ever an acceptable surrogate for surgical complexity. Not when we're talking about stage 4 disease, not when we're talking about operating after immunotherapy, really in any situation, because an expert surgeon can potentially do something in a reasonable amount of time with minimal blood loss, but require a lot of advanced maneuvers. So I think that's how we should be talking about surgical complexity, is what types of advanced maneuvers were required. And again, that's another one of those comments, one of those themes that I think isn't just true for general thoracic surgery. It's true for cardiac surgery. It's true for any operation in the chest, is that we can't just look at these things like how long did it take you and what was the blood loss, but really what types of advanced maneuvers and what type of expertise and resources are required. So I will say that for this data set, we saw that an intraoperative change in extent of resection was not uncommon, needing proximal pulmonary artery control, doing sleeve resections, reports of fibrotic or densely adherent nodes. All these different aspects were not uncommon, and these operations were more often than not reported by very experienced surgeons as being complex or challenging in the details of their operative note. Nonetheless, our 0 resections were quite common, and length of stay was typical for our cohort, knowing that in our facility we have a lot of patients, majority of whom come from out of town, and much of their discharge dates are driven by social issues as well. And the most frequent complications in this data set were prolonged air leak and atrial fibrillation, which is true in any lung cancer patient population. Although I will say, as we're operating on more and more younger, healthier people with oncogene-driven disease, we don't see these rates of atrial fibrillation like we've traditionally seen in lung cancer surgery, because they're just healthier patients who don't have the same risk factors. When we looked at surgical complexity in polymetastatic patients, this was a data set of patients from North Star and Bright Star, which were 2 prospective trials. The majority of surgical patients actually had polymetastatic disease. Here we looked objectively at overall global case complexity, severity of adhesions, difficulty of nodal dissection, difficulty of hilar vascular dissection, and without going into too much detail, I will mention here that hilar fibrosis was severe and common. Mediastinal nodal dissection was severely impacted in many cases, but it's typically those hilar lymph nodes that respond to therapy and make these operations more complicated. So anybody who's doing these operations needs to ensure that the resources and the team and the experience are appropriate for the type of operation that's being done. So what type of operation should be done? Let's talk about extent of resection. We know that anatomic resection has been thoroughly evaluated in earlier stage disease. We talk about it all the time for patients with stage 1 disease. Do they need a lobar resection, a sublobar resection? The impact in local consolidative therapy may actually be less meaningful. We looked at our own institution and found that sublobar resection resulted in survival outcomes comparable to those of more extensive resection. And we corroborated this with a multi-institutional study with the data set from the University of Zurich. It may just be that once the cat's out of the bag, it doesn't really matter whether you're able to do a good sublobar resection or an entire lobe or something larger. What about lymphadenectomy? We kind of have the same hypothesis that the whole goal is to try to do a thorough lymphadenectomy to prevent the disease from spreading. But if someone's already had widely metastatic disease, does it really matter whether we follow the Commission on Cancer guidelines for how many lymph nodes we remove? We found that local regional recurrence was similar for complete versus incomplete lymphadenectomy, and overall survival was similar between those groups. So at this point, we probably don't have enough data to say that the amount of lymph nodes removed actually matters in this group of patients. Looking at long-term outcomes, we've tried to see really what happens with survival of these patients who undergo surgery over a prolonged period of time. We know the operations are somewhat hard, but that they're tolerable. But what happens with survival? When we look at a broader period of time, when we look at patients actually out to 5 years, we can tell you that these are patients who, after median follow-up of 95 months, the median overall survival is 52 months. Median PFS is over 9 months. So this is a dramatic improvement compared to what we've seen historically in these patient cohorts. And when we look at single center retrospective analyses from multiple high volume centers, we see the same pattern. These are outcomes that are substantially better than what we've seen historically in patients with stage 4 disease. When we look at multi-center survival outcomes, we see a little bit more power to our analyses. And looking at our MD Anderson experience, along with those of the University of Zurich, which have been really led by Isabel Opitz for so many of the great studies that are being done there, I can tell you that our combined efforts show median overall survival of 78 months, 2-year overall survival of 73%, and median PFS of about 3 years. So this is really very exciting when you look at our updated data in these data sets. Another issue that I want to highlight that I think is true for all of the listeners today, regardless of whether you're a general thoracic surgeon, a cardiac surgeon, or a congenital surgeon, are that when we talk about emerging data or innovative progress in any of our subspecialties, we're always going to see disparities in the receipt of these novel aspects of treatment. And just as we do in everything else, we see disparities in the receipt of local consolidative therapy for stage 4 lung cancer. We know that lung resection as local consolidative therapy is now showing improved oncologic and survival outcomes, and that disparities are really deeply embedded in so much of what we do in thoracic oncologic care and in cardiothoracic surgical care in general. We know that these inequalities persist despite advances in treatment, which underscores the effort from equitable care for all of our patients. Here, we looked at patients in the NCDB with stage 4 lung cancer and identified those who underwent surgical evaluation. Obviously, the vast majority of patients with stage 4 disease did not receive surgery. So when we look at a cohort of 137,000 patients, only about 2,000 underwent surgery, which is what you would expect. But it's important to acknowledge with this highly powered data set that the patients who didn't receive surgery were older. Okay, that makes sense. Non-white, uninsured, and of lower income status. This is something that we need to work on. And after adjusting for clinical factors, we continue to see that non-white, uninsured, and lower income patients remain substantially less likely to receive surgery. I think it's really important for us to continue to think about these issues when we talk about innovative care for all of our patients with cardiothoracic disease. So beyond all of these survival data, what are the rationale that we discussed with patients about why we should operate? When we talk about local consolidative therapy overall, any type of local therapy, whether it's surgery or radiation for these patients who have stage 4 disease, a disseminated problem, something that's systemic, why are we doing something local that's not going to get rid of every cancer cell? We think about the idea of eliminating the primary source of subsequent metastases. We think about minimizing the number of tumor cells that are able to develop mechanisms of resistance to a drug that might be working. Many of our patients with stage 4 disease who are in a younger group of patients in this current era have EGFR mutations. One of the better drugs we have for EGFR mutated lung cancer is osimertinib. The median time to development of resistance of osimertinib is 19 months, which means about half of the patients who are having a great response to osimertinib won't be responding anymore after a year and a half. So we're trying to minimize the opportunity to develop mechanisms of resistance to these drugs. If we debulk the primary tumor, we can hopefully leave lesser disease burden for the effective drugs to work. And we talk a lot, or at least I speak a lot to patients about converting a lethal disease to a chronic disease, not necessarily no evidence disease, and certainly not a single cell of disease, because we can't prove that. And anybody who promises a patient with stage 1 lung cancer that they've given them long-term survival and provided them a cure is also being dishonest. We know that a substantial portion of patients, even with a curative resection, a so-called curative resection for stage 1 disease, are going to recur. So I think our goal needs to be thinking about longevity and quality of life, not necessarily promising patients the absence of any cancer cell or any cancer treatment for the rest of their life. So these rationale that I have listed here are all for local consolidative therapy in any form. But what about surgery specifically? What's special that we can do as surgeons? The practical reasons for surgery is that we can obtain tissue for updated pathologic response and mutational analyses. We can address any residual cells that may be left after radiation to provide durable control. I've operated on a number of patients who had radiation as their means of local consolidative therapy. And then even though they didn't have any definitive evidence of residual disease, their pathologic specimens still demonstrated 20 to 30% viable tumor cells. We know that for many patients, quality of life can be impacted from turning over every stone, dotting every I, crossing every T, and telling their young children that they've really embarked upon the most aggressive means of getting rid of their tumor. And there's this patient and family closure of answering unknowns. We know that our imaging isn't perfect. We think our imaging tells us if a malignant effusion is gone or if it's still there. We don't actually know. And really, we know that, the truth lies really in the operating room and under the microscope. Whereas I like to think of really our imaging as just an approximation of truth, and that what we see under the slides is being the reality of whether there's really any disease present or not, whether there are still mutations, whether mutations have changed, whether there are any co-mutations that we can address, any new drugs that may work. The more tissue we have, the better we can do for our patients. So a different way to think about this is in this big purple circle, I've listed all the reasons why we might want to do any form of local consolidative therapy. And in the yellow circle, I have the reasons why surgery might be helpful in any patients with stage 4 disease. Specifically in oligometastatic disease, we really do want to try to get comprehensive local consolidative therapy to get rid of all of the disease, ideally. Ideally, we get rid of every site of disease if we can, but we need to recognize that polymetastatic and oligometastatic are not the same. So I tried very hard to distinguish these two groups when I talk to patients. For those with polymetastatic disease, there are big things we can do to help them. I do believe that we can delay time to development of new metastases, we can keep effective drugs working for longer, that we can help those patients have a better quality of life, and we can help them in many ways. But we do need to understand the difference between taking out a solitary metastasis in the primary tumor or having a situation with someone with polymetastatic disease where perhaps we're taking out the primary tumor and then we are continuing to treat any residual disease with an effective drug that is working well. So it's important to understand with each patient what their extent of disease is and what the goals are of the surgical therapy. So if we are going to operate, there's all these questions. Which patients, how many metastases, what's the best timing, and how do we address these things I mentioned before? Extent of resection, nodal evaluation, operative approach. And like anything else, it's always good to have a clinical practice guideline. So this was a clinical practice guideline that we began working on in 2023, in late 2023, and was very excited to be able to publish this in early 2025. This was through the Society of Thoracic Surgeons, and this is a clinical practice guideline, which is one of our stronger consensus documents rather than just a consensus paper. And so we assessed levels of evidence and formulated recommendations. The major findings are shown here, but I'm going to summarize them for you. And the guideline summary is that strong recommendations support consideration of lung resection as local therapy in oligometastatic disease. All patients with oligometastatic disease should undergo multidisciplinary evaluation, including consultation with an appropriately experienced thoracic surgeon. Those are the strong recommendations. Moderate recommendations include lung resection for well-selected patients, even with more than 3 sites of disease, and select groups of oligoprogressive patients. And that there's insufficient evidence at this time to make strong recommendations regarding how much lung you should be removing, how many lymph nodes you should be removing, or which operative approach. So these should really emphasize patient safety. Take out as much lung as makes sense to keep the patient safe. Take out as many lymph nodes as you can without risking any injury to any major vessels or airways, and use the operative approach that's safest in your hands. But the key take-home point here is that all patients with oligometastatic lung cancer should absolutely undergo a multidisciplinary evaluation, including consultation with an experienced thoracic surgeon. So we talked a little bit about oligometastatic disease being a gateway for these other opportunities. And I like to think about it like oligometastatic disease being a disease of its own, because the criteria for surgery are more stringent than earlier stage disease, but less stringent than for polymetastatic disease. Intraoperative considerations are that dogma for earlier stage disease related to extent of lymphadenectomy and resection may not apply here, but the benefit of an R0 resection is certainly more relevant in oligometastatic disease than in polymetastatic disease. And then we think about management of other sites of metastasis. Comprehensive LCT does matter for oligometastatic disease, but it may be less applicable to polymetastatic disease. We're relying a little bit more heavily on the use of an ongoing drug therapy that can continue to manage these other sites of disease. And that's predominantly effective for polymetastatic disease. We think probably in patients who have oncogene-driven disease. When it comes to patient selection, like anything else, of course, they have to be a good candidate for surgery. If there's sites of disease that can't be treated with local consolidative therapy, they need to have options for systemic therapy, and should always be a multidisciplinary discussion. These other considerations, should we be operating if they're polymetastatic? Yes, we often do, even with bony metastases. Can we do an immunectomy? Yes, although rarely. It's got to be the right patient, the right circumstance, probably someone who's going to have total consolidation with this operation. Can we do it in pleural disease? Yes, but I think only after clear resolution of an effusion. And can we do it if they're progressing? Yes, but only if the progression is limited to the areas that are treatable with local therapy. We've written a bit about the timing. I won't go into it in great detail right now, but I think it's important to recognize that most of these targeted therapeutic agents reach their plateau of efficacy after about 3 months. So it's really important that after you initiate the targeted therapy, we don't want to tell patients, well, wait until you progress. If you wait until they progress, then it's possible you will lose the window of opportunity. We believe that that window of opportunity begins probably 2 to 3 months after they've started a targeted therapy. We don't know when it ends. We don't know when they're going to develop resistance. We don't know when the drug's going to stop working. So we try to get them across that finish line if they are a candidate. There are all these unresolved issues, though, that continue to remain about extent of resection and maximum number of metastases. And how do we do this interplay with radiation so that we're using all the modalities that are available? And what about patients who don't qualify for existing trials? We do have a registry trial that we opened in late 2023 at our institution with the primary objective to look at lung cancer specific survival at 5 years among patients undergoing local therapy for oligo and polymetastatic disease. And we're looking at all these different aspects and how they impact survival and recurrence. I do want to mention that this is a multi-institutional trial. Patients can be enrolled up to 12 months after their operation or 60 days before their operation, so that we can look at these outcomes and really put all of our efforts together. Our goal enrollment is 500 patients. We've already enrolled about 75 patients at our institution, and we very much would welcome the opportunity to bring in data from other institutions. Ultimately, I think in order to move the needle forward, we need to consider offering surgery to more patients with oligometastatic disease, with oligoprogressive disease, and even polymetastatic disease, and we need to track the outcomes. We absolutely need to collaborate. We need to think about hybrid approaches to surgery and radiation. We need to support one another across all of our specialties. We need to eliminate competitive attitudes and have more of a team culture, thinking about how we are valuing the goals and objectives and really important values of our patients more so than our own. And again, multi-institutional experience is incredibly important. And so I would highly welcome anyone who wants to be part of this multi-institutional trial. And with that, I would be excited to move on to the discussion. I thank you very much for listening to me. I know that if anyone is watching this after the fact, they'll probably have to slow down the speed, but I get really excited to talk about this topic, and there's so much to share. So I apologize for the rapidity of the discussion, but I'm excited to move on to the discussion with everyone here. Thank you so much.
Thank you so much for that, Dr. Antonoff. That was very informative and raised definitely questions that we have and that my panel / moderator members will ask with me. And I'll start off with kind of maybe a softball question in the sense of patients. So I often find that patients who are choosing between surgery and radiation for various stages of diseases want to know, which one's better? Which one's curative? Kind of what is your spiel that you give patients when they ask that question? Because I think that's something all of us probably struggle with.
Yeah. So I think in this situation, and again, I because I know we have a wide audience here, I'd love to look for things that are similar to cardiac surgery as well. I think for me, honesty is absolutely the best policy. I never exaggerate our data. I'm very clear about what the data are and then what are my beliefs? What's my gestalt? And so I will tell patients, here's the reasons why I would want surgery if it were me. But these are the limits of what our data show. We will probably never have a head-to-head comparison of surgery to radiation. I will actually even give them an example and explain why for myself, I really would want surgery, and why for my 84-year-old father, I would absolutely want radiation. I explain the differences and talk about why. And even sometimes it's not even necessarily difference in physiology, but sometimes personality. So I might not pick the same thing for myself as I would for my husband. And not related to our health status, but more so that I know that I am a person where I would have a better quality of life if I knew that it was out of my body and I knew what the slides looked like. I knew what my current mutational status was. I would know the truth about whether my pleural was still involved or wasn't involved. All of those elements would be helpful to me, and then I would use that data to make differences. If it's someone where it's not going to change their eligibility or candidacy for other treatment, they're higher risk for surgery, and that little bit of knowledge isn't going to make much of a difference, but they're really high risk, I think that's a problem. And I wouldn't recommend surgery. Where we've really been pushing the envelope, and I find where, you know, a lot of these things I've learned, I initially said nobody with pleural effusions, and now we do. Nobody said prior radiation. We have. The place where I found myself pushing the envelope the most and doing things kind of for the first time has often been in these patients with oncogene-driven disease and people who are very similar to me, people who are in their mid to late 40s with children who are just starting their lives, with careers that they are just starting to see, you know, becoming successful. And I can really understand why folks in that situation would feel a strong desire to go to surgery. And frankly, we need to recognize that most of our data about risks of lung cancer surgery are from a patient population historically that's 68 to 72-year-old smokers. I mean, that's not who most of these patients with stage 4 are that are coming to us for surgery. These are people who are young and were told for 2 years that their cough was from COVID or from, you know, pregnancy or something else. And then they have stage 4 disease, and now they are desperate for something aggressive. And so we need to recognize that the risks of their surgical procedures aren't going to be the same as the risks of our historical patients in all of our previous data sets either. So ultimately, I don't think either one is better. I think we need to be able to tell patients that both have an important role. We need to be friends with the radiation oncologist. We need to let them know that if we're turning this into a chronic disease, that they may need both over the course of their lifetime. And so maybe we take out their primary tumor, we get some good pathologic data, we look what's under the slides, we get some information, and then they get that scapular metastasis radiated. And then maybe if something pops up in a lymph node in 3-4 years, that gets radiated. We need to prepare them for the fact that there is no one solution, but it's a collaborative team-based approach.
Thank you.
All right, I'll jump in with the next question. So you mentioned that the information from the operation can sometimes change the course of care afterward. Can you talk a little bit about how the multidisciplinary team uses the data from your operation to optimize therapy?
Yeah, absolutely. I think there are, you know, really several ways that it can adjust the treatment. We may identify an additional mutation that we didn't know about before, for which we may either have an approved drug or there may be a clinical trial for a drug that's available. So either on the market or part of a clinical trial. We may identify that there is much less disease than was presumed. And so for a patient who's having toxicity from their systemic therapy, we may be able to afford them a break and be able to really, you know, let things less lighten up a little bit. We may identify persistent disease in perhaps in lymph nodes that we didn't know was there. And maybe we clear out the nodes on one side, but then they have contralateral nodes that can be radiated. And we presume that the nodal response on one side is the same as on the other side, even without necessarily needing to sample the other side. Sometimes we can identify, unfortunately, you know, things that are really aggressive, like maybe there's zero response, maybe, you know, 100% of the tumor is viable, all of the lymph nodes are positive, and things are still quite aggressive. And in those situations, we may say, you probably should stop the targeted therapy that you're on, and either you go on this clinical trial or we escalate care to, you know, escalate your systemic therapy to traditional cytotoxic chemotherapy. So I think it gives us opportunities to escalate care. It gives us opportunities to kind of scale things back. It gives us opportunities to enroll people in trials, try new drugs, take treatment avenues we might not have been aware of, but also to maybe complete the job in a multimodality strategy, really utilizing the input from our radiation colleagues. It's not us versus them. I think that's one of the most important points here is it's never us versus them. It's how can we work together?
And I have a question for you, Dr. Antonov. You having done, I'm sorry, you haven't done more of these operations than most of us. How do you tackle a case? Let's just go through a scenario in which this is somebody that may have an oncogene-driven disease and is young and healthy, and you want to do everything you can for this person. One thing that I didn't hear you talk about much in the criteria is resectability, right? And that is kind of in the eye of the beholder. But knowing what you know about the literature today, if you're tackling a case and suddenly you find yourself in an R1 or R2 resection scenario, how aggressive are you? You've learned by taking the tumor out, that's going to be great, but you probably are not clearing the whole disease. So how do you maneuver that situation in somebody with oligometastatic disease?
Yeah. So I will tell you that my timeout at the beginning of the operation, anytime we do one of these, I have like some additional language that I share with the team that if this is someone with polymetastatic disease, not necessarily oligometastatic, but even stage 4, anybody stage 4, I remind everyone, this patient has metastatic disease. This is not going to be curative. There will be some cancer cells left in their body somewhere, whether we believe it or not. There's probably some cancer cells somewhere in their body. The most important thing for us to do is to get this patient back to their family and back to their life that they enjoy right now. That is the most important thing, safety over all else. And that's really what needs to be our emphasis. So, in the operation, ideally, if we could do something that's sublobar and get the primary tumor out and clear all the lymph nodes, that's the best of all worlds. It's not usually the case. Most of these operations end up being lobectomies just because of where the tumor is and what's going on. But, there have been plenty of situations where we find nodal disease that can be partially resected and some nodal disease that is so firmly adherent to pulmonary arterial branches that I don't go doing like arterioplasties unless it's the only way to finish something that we got started. But mostly safety is really, really important. And Dr. Bostock, I think you know me pretty well. I don't love seeing the inside of the pulmonary artery. It's not like one of my favorite things to do. I try to avoid it. So we really have to emphasize safety over all else. And I think I will even tell patients at the end of an operation and say, listen, we most distinctly left a part of a lymph node here, left part of a lymph node there, but let's see what the pathology looks like. And depending on what it shows, then we can make decisions. And oftentimes, when it was something that was so stuck that it was impossible to remove, you'll find that none of the nodes had residual disease anyway. It was all fibroblasts. And so, no, then there's nothing to do. And you're happy you left those fibroblasts on the vessel rather than ripping them off. In contrast, if you leave something and all of the nodes end up being positive, because it's usually a node you end up leaving behind. It's usually a node problem. And if you leave a node behind and you find that all of the nodes are positive, those are situations which you might, want to offer radiation to that node. Although I would say the vast majority of times where there's been something that just doesn't feel safe to get out, it ends up being because it's all fibroblasts and there's no cancer cells left in that spot. I'd say one of the most common pathology that we see in these patients who've responded to extensive systemic therapy, really effective systemic therapy, is we often see either partial response or complete response in the nodes, and the primary tumor almost always has some residual disease that could range anywhere from 20%, 30%, 80% are numbers that we often see.
So I have a question about precision medicine. I feel like that's a hot topic. And you alluded to genomics earlier. I'm just wondering if there's anything you can give us in terms of what role AI or some mix of those two maybe playing in oligometastatic disease, whether it's in diagnosis or in treatment, or anything you can share.
No, I think there's a lot more work to be done here. It's a great question. There's a lot more work to be done. These are places where we need more research. I will say, even looking back at where we were a few years ago, we were exploring this in patients after immunotherapy as well. And I think for those who are familiar with the NRG LU02 trial, which did not involve surgery, it was only radiation, but those are patients without driver mutations who got immunotherapy. It was a negative study. Now, there's a variety of reasons it might have been a negative study, having to do with the methodology and whatever else, but it may be that these patients with targetable mutations are the ones for whom this is going to be the best. And it may not be something that's going to be very helpful for patients who don't have a targetable mutation that we can address with a straightforward drug. But I also am very hopeful that while whatever percent of patients right now have targetable mutations, that number is going to grow and grow with time. That hopefully we will, be able to tell every patient, okay, this is your driver mutation and this is the drug that we have for you. We're not there yet. I don't have the answer to your questions. I think I think that's where we need to go from here.
Kind of along those lines of frontiers and next steps, can you talk a little bit about clinical trials and how we can ensure that the clinical trials that we're doing right now include the broad variety of patients who have lung cancer? Are there any areas where we need to kind of build our recruitment so that we understand different populations and how they may be impacted by local consolidative therapy?
Yeah, I think it's a challenging question because what we are realizing is that all of the dogma that we have for surgery need to be reevaluated as to whether they make sense in stage 4 disease. And so, we have had opportunities to study surgery and radiation with a lot of novel drugs, which is great. And so I think as surgeons, we need to be engaged in these multidisciplinary discussions. And as opportunities are coming up at all of our institutions and in all of our organizations and in many of our collaborative groups for multidisciplinary care that involves systemic therapy and radiation, we need to speak up as surgeons and say there should be criteria for patients to move on to surgery in these settings. I also think that we need to do a better job of putting our surgical data together, even if it's just through a registry trial, put it all together and say, wait a minute, when we look at all of these data over 5 years from 12 institutions, here's a pattern that we see. Now here's the next trial. Because, like anything else, you need a body of retrospective evidence before you can move forward with really interventions, but it's hard to get that retrospective evidence when it's really something that people think are crazy. And so, we got our foot in the door with oligometastatic disease and a trial that allowed us to look at surgery and radiation together. And we just need to keep pushing the envelope and having a willingness to try to do a little bit more. But I think surgeons having a seat at the table, ensuring that they speak up, that when they hear new trial options, new opportunities with novel drugs for stage 4 disease, and new applications of radiation, that we're always asking, what about surgical therapy and how can we utilize it in this space?
I want to jump in before we keep badgering you with questions to ask the audience to please place any questions you may have for Dr. Antonoff in the chat so we can get to them before we wrap up. So if you have any questions, please put them in the chat.
I have a question from the non-thoracic surgeon for Dr. Antonoff. When I see this patient that lands in my office and I'm getting my cardiac workup for their CABG, and I notice they've got oligometastatic disease, and I'm not in a space where I'm surrounded by the likes of MD Anderson or Sloan Kettering or one of the other major cancer centers. We've talked about it's important to have a team that's familiar with the available options instead of having the dogma repeated. Where do I send that patient? What do I say to that patient? Are there key terms when I refer that patient to my local thoracic surgeon that I should say, when you meet your surgeon, ask this question, or you should really go to one of these centers? What's your opinion on that?
This is a really, really hard question. And this is another one of those issues that I think will face every member of the Southern, regardless of what their specialty is that we really want to be super good at something and to have great outcomes at our own centers, but we know we can't take care of every single patient at our own center. And every patient deserves access to the same treatment. The reality is that there has to be some centers of excellence for some things. And right now, I will say, before there was this explosion of stage 4 surgery really in our practice, it wasn't uncommon for us to see patients with earlier stage lung cancer that would come see us in Houston. And I'd say, you don't need to come to Houston. You've got great people that can take care of you here. I know that person, or, this person can take care of you. This is really hard because this isn't just the experience of the surgeon. The experience of the surgeon matters, but the experience of the entire care team matters. The experience of the OR staff, the pathologist, the blood bank, everyone matters. And so, I think there are so many team members that are responsible for the success, but we really do want it to grow. We want people to gain these experiences. I think, we can't take care of every patient. The 4 of us here, Dr. Wilder, Dr. Bostock, Dr. Chidi, and myself, we need patients to get their care out in the community and everywhere. I don't think right now surgery in stage 4 lung cancer is a community practice operation. And that's hard to say because patients in every community deserve access. Those can be true and separate to say every patient deserves access and deserves care, but this can't be done everywhere. And that's a really, really big question about how to fix that. I don't know the answer to that, but I can tell you that, you know, one thing that you can refer your patients to is there are phenomenal Facebook groups for patient advocacy groups that can help a lot with some of these connections, giving advice on how to get connected in the right place and where people had good experiences. You know, each of the different kind of driver mutations, they have their own groups. Like there's a group for people with ALK mutations, and there's EGFR resistors for people with EGFR mutations. And for so many of these patients who are diagnosed at under age 50, which is many of the patients with stage 4 disease, there's the Young Lung Cancer Initiative. So I would say patient advocacy groups are a great place for them to get advice about where, you know, they can, what the questions they should be asking and what they should be seeking. Ultimately, I would say that they need to be meeting with a medical oncologist and a surgeon, a multidisciplinary team that's familiar with the latest guidelines, latest recommendations, and is attending the major conferences, going to World Lung, going to ASCO, reading the papers and participating in scholarly discourse and knowing which clinical trials are available. I don't think every patient necessarily has to be directed to one of the highest volume cancer centers. But for right now, I think it's most ethically appropriate and safe to say that to have a complex operation, you need to be somewhere where there is a team that is familiar with complex operations. And I think that's fair.
Do you think it would be reasonable? Because the question I always ask is if this were my mom or dad, my sister, what would I do? Do you think it's reasonable to tell a patient if the answer is no, it's okay to ask why not, or can I seek a second opinion?
I think the answer to that should always be yes, regardless of whether you have stage 4 lung cancer, stage 1 lung cancer, whether you have a thyroid nodule. I think we should all encourage all of, not only our family members, if you're not sure about the advice you're given, to seek advice elsewhere, but you know, we should encourage our patients. I will readily tell my patients that they should seek a second opinion if they have any desire to do so. So I think that's incredibly valuable. And frankly, if any of us are unsure about the advice we're giving our patients, yes, they should seek another opinion. But even if we're confident about it, I think we tell patients that, you know, if we feel good about the advice that we've given them, that we would love to hear what other experts in the field have to say. I'm a huge fan of second opinions.
Awesome.
One additional question we had was regarding educating future thoracic surgeons that will be dealing with this. What would you say in terms of curriculum, in terms of preparing your fellows? How are you, besides like hands-on experience as they're in the OR with you, for those who don't have someone who does this, do you think that there's a need to start changing the way we're teaching this?
You know, that's a very good question. I vividly recall being a fellow at WashU and having Dr. Patterson say things like, now this is the way that we do this here, but this is not what you will do on your boards for a variety of things. And we try really hard in a cancer center where we are doing things that maybe are a little bit ahead of the guidelines to remind our trainees not only how they should answer on the boards, but how they should practice when they're independent, when they don't have the support of someone with experience. And so certainly we don't expect our fellows to go out and be doing stage 4 surgery independently the next day. But I think for our trainees who are seeing things that are emerging, we need to remain as mentors for them. We need to remain as resources. We need to help them find mentors locally who can help them do the cases safely. And so I think the best thing we can do is expose them to what our decision making is. Don't just have them watch us do complex things in the operating room, but invite them to clinic, help them understand why these things matter, why I care about if they've previously had an effusion or a brain metastasis and how that's very different to me than a bony metastasis. Help them understand why I have all these extra things on my card and that I need available for these operations. Teach them the nuances of why you're doing what you're doing, but remain available as a resource, as someone that they can bounce cases off of. And even if you continue to give them advice about which cases to do, make sure they have someone at the local level that can help them get through the operation safely.
So we are coming up on about 5 minutes left. I'm not sure if anyone in the audience is able to put anything in the Q&A. Otherwise, I will pass it back over to Dr. Barron and Dr. Edwards.
I don't know that we have Q&A. I don't know that it's coming through via the Zoom. However, we can certainly address those via our X/Twitter social media after this to expand on being able to tap into Dr. Antonoff's expertise. But just to wrap up, thank you everyone for coming and participating. And I will give the mic over to Dr. Yang and Dr. Edwards to wrap us up.
Well, first of all, Dr. Antonov, thank you so much for your time and your expertise. I certainly learned a lot during this discussion. I was gung ho and ready until you said not everyone should be doing this. Then I kind of held back my enthusiasm. But I think hopefully this can disseminate in a kind of measured way to be able to allow more people access and certainly change the paradigm and get us thinking outside of our traditional dogma. So really great discussion and thank you. I'd like to also introduce, so I'm Melanie Edwards. I'm the current president of the Southern Thoracic Surgical Association. Dr. Stephen Yang, who is on the call, is our STSA Council Chair and immediate past president. So we have exciting things coming up for STSA. This is kind of our kickoff, and we are preparing also for our annual meeting. This will be the 72nd annual meeting, November 6th through 9 at Amelia Island Hotel, Ferdinand Beach, Florida. We have an exciting program planned. In preparation for the annual meeting, some of you may already know that abstract submissions have closed, but we know that the work is ongoing, and so we wanted an opportunity for any late-breaking submissions over the summer to also get a chance to be highlighted there. So we will be opening a late-breaking summer submission. This will open July 1st and be open for, I want to say about 2 months or about 8 weeks or so. So if you have anything that didn't quite make it to the initial abstract submission deadline in April, please submit your work. We would be more than happy to review that and happy to also have you at the meeting. And then as we talk about the annual meeting, the meeting registration will be opening up in a couple weeks. So Tuesday, July 1, mark your calendars. So this would be the date not only for the summer submissions for late breaking abstracts, but also for the annual meeting registration. Register early. This is a popular site. The room block will sell out, so secure your room as soon as possible when that opens on July the 1st. And then coming up this Friday, we're going to open up the STSA scholarship application site. These are going to be scholarships for both medical students and residents to attend. We have the Brooks Scholarship for medical students and residents to attend the annual meeting. And we also have an Opportunity Scholarship. So look out for those announcements with further details. Make sure you encourage any medical students or residents who may have an interest in applying or attending the annual meeting to apply, and I'm sure they would benefit from your sponsorship. So I think with that, I'll see if Dr. Yang has any other comments that he wanted to make. And
well, again, I just want to congratulate everybody on the webinar tonight, especially Dr. Antonoff. Again, as everybody said, I keep learning from you. I know you just gave the talk at the AATS, but I know there's continues to be more information that you give to us. Also to Dr. Barron for really chairing this new committee and getting the Southern webinars off to a fantastic start. And also thank Dr. Cheedy, Dr. Wilder, Dr. Bostock for helping to coordinate the questions. Just a few more things. I don't think a lot of people know that the Southern has opened up membership to everybody. So you don't particularly have to be have trained in the Southern, but if you have a certain interest in the Southern Thoracic and if you've attended several meetings or if you've presented at several meetings, you actually are eligible for membership. So we have opened up the requirements. So not necessarily do you have had to be or live in the South right now. The South, I think, is just the whole world now. So anyone can join. And it's a rolling membership, so not necessarily does it have to be right before the meeting, but we do try to have some membership acceptances throughout the year. So 3 or 4 times a year, just please submit your applications for membership at any time. We encourage not only faculty, but fellows and residents and medical students and advanced practice people to join the Southern. So with that, I think we will conclude this great webinar. So again, thank you, Lauren, for setting all this up. It was a fantastic start, and I hope everybody enjoys their summer. And take care.